Hello, and welcome to the ongoing series of perioperative medicine video recordings sponsored by SPOCI, the Society for Perioperative Assessment and Quality Improvement. I'm Dr. Stephen Cohn, Professor Emeritus at the University of Miami, and I'll be discussing preoperative cardiac risk calculators. This slide shows a timeline of the various risk calculators going back to 1977 with Lee Goldman's original cardiac risk index, all the way up to the last few years with calculators developed by AI and machine learning. The three that you see highlighted in red were recommended by the 2014 ACC guidelines, and they're also included in the 2024 list of calculators, which has been expanded, and also includes one that I think is potentially interesting. The AUB has two. So I'll be discussing these four calculators. We'll talk about the risk factors and outcomes, as well as the pros and cons of each one. The 2024 ACC guidelines said that a validated risk prediction tool can be useful to estimate the risk of perioperative MACE, or major adverse cardiac events. They define low risk as less than 1% and elevated risk as 1% or more chance of having MACE. And here's the list of risk calculators in the current guidelines. We'll start with the Revised Cardiac Risk Index, or RCRI, or Lee Index. And this was derived from over 4,300 patients, 50 years and above, undergoing non-emergent surgery. And what's important is that you had to have a length of stay of at least 2 days. What this does is weeds out low-risk procedures, minor surgery, and same-day surgery, because you'll overestimate risk if you use it in those settings. They found 6 independent predictors of their outcomes, and they included high-risk surgery with 3 categories: history of ischemic heart disease, heart failure, stroke or TIA, diabetes, and you had to be treated with insulin to get to 1 point for a risk factor, and renal insufficiency that they defined as a creatinine greater than 2. Their major cardiac complications occurred in hospital, as opposed to 30-day outcomes that most of the newer calculators use. And in addition to MI, VFib, and cardiac arrest, they also included complete heart block and pulmonary edema. They grouped patients based on the number of risk factors they had. The more risk factors, the higher the risk of complications. And I like to draw the line between 1 and 2, where I consider 0 and 1 as low risk and 2 or more as elevated risk. Although a number of my colleagues will say that patients with an RCRI score of 1 are actually at elevated risk because newer studies with high-sensitivity troponin have shown higher rates of complications. That being said, the ACC guidelines actually back me up by stating that elevated risk is an RCRI score greater than 1 or a complication rate of 1% or more. Now, the advantages of the RCRI is that it's done prospectively as opposed to retrospective studies. It separates low risk versus high risk patients and does that fairly well. It's simple and easy to use and has been around for a long time. It's been validated in multiple settings externally. They also routinely screened for MI postoperatively. The disadvantages are that it underestimates risk in major vascular surgery, in particular AAA repair. It's a poor predictor of all-cause mortality. It's based on data that's now 25 years old, and it's from a single institution. And as I mentioned, they used an old biomarker, CKMB, which is less sensitive than the troponin we use today. They also had broad categories for high-risk surgery, and they didn't necessarily account for laparoscopic or endovascular procedures. And it's been found that you can improve the RCRI by replacing serum creatinine with creatinine clearance less than 30 and by adding age. The MI cardiac arrest, or MICA, or Gupta calculator was derived from the National Surgery Quality Improvement Database, or NSQIP, and they excluded trauma and transplant patients. They used over 200,000 patients to develop it, with another 250,000 patients to validate it, and they found 5 predictors of their outcomes, which included MI or cardiac arrest, and it was a 30-day outcome. Their predictors were the type of surgery, and they expanded it to 21 categories. Dependent functional status. Here, an abnormal creatinine only had to be greater than 1.5. The ASA, or American Society of Anesthesiology classification, and increasing age. The advantages of this calculator are that they felt that they had better discriminative or predictive ability for MI and cardiac arrest when they compare themselves to the RCRI. This is also an exact model-based estimate as opposed to the RCRI where everything got 1 point. They were all rounded off to the same level of importance. And this is more surgery specific than the RCRI. Its disadvantages are that the NSQIP database lacks data and information on coronary artery disease, cardiac tests, aortic stenosis, and use of beta blockers. And they may miss NSTEMIs because if it's less than 3 times the upper limit of normal for the troponin, they didn't count it as an MI, and they also did not do routine screening. And you need to use a smartphone or computer to use this calculator. The next one and most comprehensive is the American College of Surgeons NSQIP calculator. And you can see here that there's a lot of things to fill out. You start with the procedure up at the top, and you need to put in a CPT code. There's over 1,500 surgical procedures, and then there's 20 other fields that you have to complete. And although it looks imposing, it only takes 1.5 to 2 minutes to do. What's nice is that it gives you this nice color-coded display where you have the patient's risk, the average risk, and whether that risk is above or below the average, and it's color-coded with red being above average. And in addition to predicting cardiac complications, it also predicts death and a whole slew of other complications that you see here. The advantages of the ACS calculator are it's the most comprehensive, predicting multiple complications, as noted, and it covers most operations across multiple subspecialties. It also includes a surgeon adjustment score where if they feel that the procedure is not really accounted for properly, where the patient has some specific risk factor that's not in there, they can adjust it. The NSQIP calculator is recalibrated frequently, and by having that color-coded visual display, it offers benefits to patients, families, and healthcare providers in the sense that it's a decision aid that you can use for discussion and informed consent. The disadvantages, the same issues with the NSQIP database, missing information. This is the most complex with more data to enter, and you certainly need a smartphone or computer. It's been found to be somewhat less accurate compared to procedure-specific calculators like one for colorectal surgery. It has a tendency for the predicted risk to be overestimated at both extremes, the lowest and highest risk patients, and underestimated for those at moderate risk. And it doesn't account for the indication of the procedure or for multiple procedures. One of the newest calculators that's listed in the 2024 guidelines is the AUB HAS2 from the American University of Beirut. And this was a prospective study of over 3,200 patients aged 40 and above, and it was validated on over 1 million patients from the NSQIP database. Their outcomes were death, MI, and stroke, and it was a 30-day outcome. Their risk factors, and this is where the HAS2 comes in, the 2 H's are history of heart disease and heart disease symptoms. The 2 A's are anemia and age 75 and over. And the 2 S's are surgery, vascular surgery or emergency surgery. They grouped the patients into 3 categories. And you can see here on the graph that they did fairly well in terms of having a good association. The more risk factors you had, the higher the risk of complications. And the derivation and validation sets matched up very well. So, which calculator should we use? Unfortunately, there's not a good answer, and there is no one that we can say is better than the other, because you can't compare apples to oranges. These are not true head-to-head comparisons based on a lot of differences in the calculators. So what do we do? What's the bottom line? You need to understand how each one was derived. What patient population was studied? In what setting? Did it include emergency surgery or just elective? What procedures were included or excluded? Neurosurgery, vascular surgery, trauma, and transplant, for example. How did they define their risk factors? What were their outcomes, and what was the time frame? It's been shown that all of these calculators appear to work reasonably well to categorize patients as low versus elevated risk when used as intended. So if you have a patient that fit into the study the way it was done originally, it's good. But once you take it to a different situation, there's a lot of variability and they don't work out as well. Don't use the RCRI for low risk or ambulatory procedures. You'll overestimate the risk. And don't use it for major vascular surgery. You'll underestimate risk. Remember the different outcomes and follow-up period. The RCRI was in-hospital only. The MICA and ACS surgical risk calculator with 30-day outcomes. The ACS surgical risk calculator is the most procedure specific and comprehensive. And as I mentioned, it predicts multiple complications in addition to cardiac. And what I would suggest is that you consider using more than one calculator. So for example, the RCRI and the ACS calculator. They should correlate and agree. If they don't, you need to sit down and figure out what the issue is because something's not right. But remember that the history and physical are the most important, and that these calculators are only tools to assist in shared decision-making, and they should only be used as such. You are the ultimate judge. Use your knowledge and decision-making to decide what the patient's risk is. Thank you.